and welcome to Patient Preferred Presents. On this amazing new show, we will be introducing you to some of today's top physicians and leaders in the healthcare industry while sharing new discoveries, medical procedures, expert advice, and answering all of your healthcare concerns. So stick around, you don't want to miss today's episode.
Hello and welcome into another edition of Patient Preferred Presents. Today I'm very excited to introduce you to Patient Preferred Nephrologist Dr. Ronald Hamner. Now he has been retired for a year, but he has spent his entire career focusing on the needs of his patients and really focusing in on that individual relationship, getting to know the patient so that you can properly treat them. And to that, he has written a new book called Rescuing the Patient-Doctor Relationship. And it really does a deep dive into how we pay doctors, the regulations involved, and he comes up with a lot of great, important solutions that I think need to be looked at. But more than anything, I just loved hearing him talk about his relationship with his patients. And you can tell he misses that aspect as he's been retired now. All right, Dr. Ron, it's a pleasure having you today. I'm very excited to hear about your story and your new book. I think that it's groundbreaking in many ways. Tell me a little bit about yourself. How did you decide to pursue medicine?
Well, it began actually in high school plays. And the director says, I wanted to cast you for the doctor because I thought you looked like a good one. So really? that really kind of got my thoughts going that way. Although to tell you the truth is my grandmother who loved doctors and wanted all of her grandchildren to be doctors, and she had an influence as well. So when I went to college, I thought I was going to start off with math, but I quickly changed to pre-med and focused on medical school and went straight from Trinity University in San Antonio to Vanderbilt. And it's been going on since then. So I was made to be a doctor or be a nephrologist, I think. I think that's my purpose in life for my professional years. And that's where I was very comfortable. The way was lubricated. I mean, I basically applied to Vanderbilt because of a suggestion from someone in North Carolina, and they liked me, and I said, well, that's great, I like you, and that's why I went to Vanderbilt. And then after that, I went to a training in Alabama where my wife, we got married during medical school. My wife was in dental school. So we didn't live together the first year of our marriage. We were in separate cities. And then because my wife is from San Antonio originally, we headed back. So I did my fellowship in Houston, University of Texas in Houston. My wife went on faculty for 2 years in dentistry. And then we came to private practice in San Antonio. So that's the journey. I chose nephrology because I thought they were the super internist. They had to know something about everything. And I was very impressed with that. Of course, that was my first rotation as an intern, so that may have had some impression on me that way. But that's how I looked at nephrology, and I consider nephrology to be applied physiology. And I look at myself as an applied physiologist. So I loved the physiology. I loved the interaction of the various systems in the body. And I loved being able to try to manipulate a good outcome by doing different things, not necessarily primarily with the organ system that was involved, but the other organ systems that were interrelated in what they did. And so that always fascinated me, and I like doing that.
Yeah, well, that's a fantastic story. I love that somebody told you in drama that you would be a good doctor, and you're like, okay, and here you are. Now you're retired. How many years later, having been a doctor your whole life?
Yeah, 37 years of practice in San Antonio. Um, had thousands of patients, and worked as CEO of the group for just over 8 years, and was just a bitch nephrologist for the rest of the time as well. And I did dialysis. I did all forms of dialysis for patients. Home dialysis was actually one of my fortes. Um, so that's how the practice went, and it was a huge number of patients because San Antonio has a lot of kidney disease, and I didn't know it at the time I came here, but it's diabetes and hypertension here. So had a lot of worked long hours. The 60-hour week was usual. When I was CEO, the 80-hour week was usual.
Wow.
And,
Wow. So you've been very busy. Now you've been named a patient preferred nephrologist. What does that mean to you?
Well, it means that I succeeded in not only taking the best interests of the patients to heart in what I did for them therapeutically, but also I succeeded in engaging the patient in their care.
Mm-hmm.
People want to have someone who cares about them individually, and they want to do what they can do in their health care and trust that what they can't do will be done for their best interest. I mean, that's a basic thing that a lot of people have.
Right.
And so the accolades signal that I had some success in doing that. And to tell you the truth, you cannot be successful in nephrology unless you engage the patient into the care. It's too complex. There are too many things that have to be done to take care of a kidney patient. And it includes exercise, the right kind of diet, manipulation of medications, being willing to take medicines away, keeping the people active and engaged, taking care of the depression that occurs when someone is told they have kidney failure. I mean, there's a lot of different things. Engaging in bringing the family together to help, because the support system really makes a big difference. So Patient Preferred tells me that I was successful in doing some of that.
Well, that's fantastic.
I want to maintain the relationship even after retiring this past year. I received gifts from people, and they wanted to go off and play golf with me, or dinner or something like that.
We are speaking with Patient Preferred Nephrologist Dr. Ronald Hamner. We are talking about his new book, Rescuing the Doctor-Patient Relationship. So let's continue.
Yeah, I love that. I'm curious. You've been retired for a year now. What do you miss the most?
Getting to have the one-on-one with the patients. I was a hands-on kind of doctor. So if you came to see me, I talked with you, and then I examined you by putting my hands on your body, and then I came back after everybody's dressed and all the hands are washed and things like that, and I sat down and told you what I thought. And so I miss that part of it. I don't miss the regulations. I don't miss the requirements. I don't miss all the metrics that are imposed. I had to deal with all those for a long time, but I don't miss them at all. And so that's just person-to-person relationship, and you can get that outside of medicine. But it's special in medicine because the doctor and the patient relationship is very intimate. It's people would tell me things that they wouldn't tell anyone else, and I had to have the trustworthiness, the fiduciary responsibility to guard that information. And it's not a legal necessarily, well, there's legal parts to it, but it's not just a legal relationship like a doctor, like a lawyer and a client. It's a very personal, intimate relationship because the patient depends upon the doctor to be able to receive all these bits of information, some of which were not pleasant, some which told me that they weren't doing anything I wanted them to do, but still care for them, still try to provide the best for them, and even if they were kicking and screaming against it, to try to guide them down the pathway that I thought was best for their outcomes. Which actually I talk about that in the book some too. But
well, let's do that. Let's talk about your book. I know you've already mentioned a lot of things that are in the book. Tell us why you decided to write this book. What was your motivation?
Well, it began when I was eating dinner with a friend who was a CEO for a large dialysis company. And he was talking about his mother in Sweden and how things were done in the hospital when she was in the hospital, and no one talked to her, and they didn't know what's going on. And he thought that some of the decisions weren't the best decisions. And we talked about it, and I told him basically the type of things I just told you. He said, "We ought to write a book."
Mm-hmm.
So I sat on that for about 5 years and finally decided, well, maybe I should. So when I looked at it, I have the hypothesis as that the quality of care and the best patient satisfaction is provided at the point of service between the physician and the patient. It's not elsewhere. It's not in a boardroom. It's not in a committee room that's looking at metrics. It's not at the actuarial stage of looking at finances, but really is provided there. Although, all the hospitals and the insurances and Medicare are all looking at these numbers. Do that number come up right?
Mm-hmm.
What your patients hit that number? So I said, well, we have to look at that. But then I said, well, what's impinging on that? And so I went back and did a historical study of how the doctor-patient relationship has evolved, even going back to ancient times, and the financing of medical care. And there's nothing new under the sun. So back in ancient times, there were a few people that could afford their own medical care. And in fact, those people back in ancient Rome had slaves who went to medical school. So most physicians back in those days were slaves because they couldn't afford to go to medical school. I mean, there was a doctor named Galen who was the exception, but his dad was really rich. So otherwise, the payment was that way, which that's kind of like an HMO almost. Or the government service. If you were in the military, you had doctor services because the military was very valuable. The soldier was very valuable, and you had to do things to restore that soldier to battle.
Mm-hmm.
And then you had plans that were paid for by a temple tax. And you see that in Palestine and ancient Israel. Mm-hmm. The temple tax, basically the priests were the physicians too. And they got supplied by temple tax. And then you had to pay a fee for service if they did something for you. You had to go give your offering.
Mm-hmm.
And the rest of the time it was all bartering. You went to the village herbalist and you hoped that they could help you out because they could only do acute care medicine. And so acute care medicine has been the way in which things have been done for centuries. There have been different ways to try to pay for it, but basically they still end up kind of the same thing, a fee for service or an insurance plan. But things changed in America starting in the 60s, really. And we had something called medical progress. And we changed our care from being acute care to being chronic care. So no longer is it You go, and if you're sick, you get either well or you die. Now you have medications so that diabetes doesn't kill you right away.
Mm-hmm.
Heart disease doesn't kill you right away. Cancer doesn't kill you right away. Kidney failure doesn't kill you right away. We didn't have the first dialysis machine was invented after World War II, and used on a Nazi collaborator who was an enemy of the state and was treated. But the system has changed as far as how we do care, because we now have long-term management of diseases. And that's great for getting to know a patient and continuing to work with the patient, but the payment system and the regulations of that are still based upon the old-fashioned acute care single service.
Right.
So the payment systems assume that we would have, say, 2 to 4 encounters with physicians a year. That's the insurance plan that came out after World War II, and including the Medicare plan, which is basically government insurance company, Medicare. But now we are different. So as a nephrologist, I saw patients on dialysis, and they were on dialysis. They had acute encounters with the medical service 3 times a week, plus encounters with other physicians if they were diabetic or had heart problems or whatever. So a dialysis patient goes from being 3 or 4 times a year to 150 or more a year.
Right.
But the fee-for-service pattern of payments and regulations still are being used. We have an advanced way we do things, and it's going to implode. The system will implode because we can't afford the cost. It was over 18% before COVID. Now I haven't seen any statistics about what it is after COVID. But 18% of the GDP is used to pay for healthcare based upon a fee-for-service system.
Mm-hmm.
And so when it gets expensive, what do? Well, they make regulations that interfere with the doctor-patient relationship. They make you follow an algorithm for how you care for them. And instead of having a discussion with your doctor about what you want and what's the best way to get there, you have to follow the algorithm. Or you have to do pre-certifications, or they just won't cover it, or they change the cost to make a copay that's very high. Deductibles being very high.
Mm-hmm.
That's what happened after the ACA was passed. And so there have been numerous ways to try to fix this by regulations and by payment systems, but they fail to see that they're still trying to do the old fee-for-service. That there's an irresistible urge to micromanage everything.
Yes.
Teddy Roosevelt wrote about that, and he talked about why you didn't need to have the government micromanaging. And so I actually quote some of his sayings and some of his thoughts in the book.
Mm-hmm.
But there's a micromanagement, so you're going to tell people exactly how to do everything. But that means the manager doesn't trust the people that they're managing to do the job.
Right.
So that's when they come in and say, well, you have to do it this many ways and that ways. And that's how the regulation has come into the medical practice, to tell them that to do things this way. So, for example, if you go into Medicare and you have your Medicare, welcome to Medicare physical, they have to give you a certain test to see if you're depressed.
Really?
Yes, otherwise they won't get paid.
Okay.
They have to do something to check your cognitive ability. You have to remember 3 words. Not for long, though. It's not a true thing, but that's the way in which you do the test. And so we get things being done for form, to check boxes, to follow an algorithm, but not based upon the true interaction between the doctor and the patient. So I think that we have to remedy the system in a lot of different ways. Number one, to keep it viable financially. but also keep it viable as a way to take care of people.
Yeah. Yeah. And I can tell, just having sat with you here for a few minutes, that you want to treat the individual patient. You don't want to treat a form. You don't want to create an algorithm, right? So how do we return to that? What type of payment system have you thought about? Different solutions and ideas. What's the return to good doctor-patient relationships here?
Well, I actually had 9 general areas to work on, including legislative ways and pharmacy and all that type of thing. But I think to return to the relationship, I think we need to put the power of the purse string at the point of quality care. That means the purse string power needs to be something that's handled by the doctor and the patient. And you can only do that if you give a budget. So this is going to require a radical change. If you give a budget for handling the disease, and there's plenty of data out there about cost of diseases on average. And that data has been accumulated for years, especially since Medicare came around. So say, for instance, dialysis patient on hemodialysis costs $83,000 a year on average. Understand that there are catastrophes that happen. Well, so you take the $83,000 and you have to train the participants. We say, okay, this is your budget for the year to take care of your kidney failure. And so some of that's going to go for dialysis treatment, some of that's going to go for drugs, some of that's going to cover catastrophic insurance, some of it's going to cover the other physicians that may be needed for physical therapy, hospitalizations, all that stuff. We have ways to see what the usual, and then you say, okay, to the patient, the doctor and the patient talk and say, well, how do we want to handle this? This is all the money you got. It's not unlimited. So there's a budget. That means that they can make budgetary decisions by the people that pay. The government can make budgetary decisions about financing Medicare. You have a budget. You have catastrophic insurance to take care of the outliers that cost $1 million. But the purse string is handled by the doctor and the patient. They say, well, this is what we want to pay for. And so that means if there are 3 alternates therapies, you have to go through with the patient and say, well, this one has the highest probability of helping. This one has low probability of working, but is a home run, or whatever it is.
Yeah.
And then the patient will tell you, well, this is what I want to go through. I'm willing to do this much. I need to stay alive until my daughter graduates from college in a year and a half, or whatever it is. You see, those concerns can help to tailor the prescription. So I think that's one way in which we have to do it. We have to budget money, including for wellness as well as for chronic diseases. And instead of paying fee for service, unlimited, which we try to control by making a high copay or high deductible or whatever, we put the money there and say, this is the amount of money you have. Now, if you do a really good job of taking care of this and preserving health and doing it without duplicating services all the time, not having 5 MRIs or whatever it is that happens, and I've seen those happen. But if there's money left over, guess what? The participants get to have money. So that includes all the providers, plus I think the patient should be eligible to have an HSA that's funded by this, regardless of age. You know, HSAs cannot be held by people who are on Medicare. I mean, they can't be funded.
Right.
So I think that if everybody does well with how they deal with the money, then even the patient gets to get some money in an HSA. This goes for medical use.
Mm-hmm.
Can't go for beer, but for medical use. Mm-hmm. And I think that way you reward everyone to be engaged. Now, to make that happen, we have to train doctors to be money managers and to deal with this type of collegial team therapy type of thing, not operate in silos. So that's require training time with physicians in the field and therapists and nurses and everybody else, whoever will be a participant. It requires changing how we teach physicians in medical school to not do things in a silo, but to do things as a collaborative effort. We have to train patients how to be patients.
Yeah, I really love this line of thinking, because I've always thought that one of the biggest problems right now is the patient, me as a patient, me personally. I don't really know what my doctor charges. I don't really know what those services cost, and I'm honestly not even thinking about that. I'm going to pay my copay, and somewhere down the road, I'm going to get a bill for the difference. And to me, just from a standpoint of capitalism and all of those things, that's just the worst way to do things, and it distances you from the concerns of your care and the decisions of your care. So I love this. I've thought as a solution that insurance companies shouldn't pay providers directly. They should pay patients, and that's basically what you're saying. And then the patient goes out and decides how that money is going to be used and spent. We need to return the patient to the process of their own care. Yeah,
exactly. In fact, I discussed that very problem. Mm-hmm. The removal of the patient from the financial process, because now instead of patients paying doctors directly, doctor, how much are you going to charge me for this? Blah blah blah. Okay, can you do it for this, or I'll just pay it? Now, all the negotiations about prices are done third party.
Mm-hmm. Yep.
So that has to change.
Yeah, I agree.
So there are other components to this. The pharmaceutical industry needs to stop subscribing to commercialism in the pharmaceuticals. They are very important, and we have a tremendous amount of innovation. And innovation is expensive. It costs anywhere from $400 to $800 million to bring a new drug to market if it's brand new. And so they need to be rewarded by paying for that and having a profit. I mean, if they don't have a profit, they can't stay in business.
That's right.
But I am deeply distressed when I see drug commercials on TV. I mean, that should be the decision of people that are professionally trained to handle drugs.
Yes.
And it should be a discussion with the patient. And I don't assume that patients have been trained to know all about pharmacology.
That's right. But they see that commercial and they see all those solutions. Of course, they always hear that it may kill you. You always have the disclaimers on there as well. So I'm like, which is it? But I just always picture them going into their doctor and saying, give me this because I saw a commercial. And wow.
That's not good medicine.
No.
And in fact, if the doctor hasn't already recommended that line of medicine for the patient, maybe you need a different doctor. But
yeah,
as a nephrologist, I would sometimes use medications for their side effects because kidney patients tend to show the side effects.
Right.
And some of these drugs had side effects that I wanted to use. There's a medication, the name was Megase, and it's Megestrol, and it was a poorly effective drug for breast cancer. It just didn't work very well, but it made people hungry. So for decades, I would give it to my dialysis patients who weren't very hungry, because bad nutrition and kidney failure is not a good combination.
Doesn't work, yeah.
And I would use it for the side effect. You know, there are other things I did like that.
Mm-hmm.
But, so, you know, commercialism in pharmacy is not good. And I think we need to encourage the pharmaceutical industry to retreat from that position. And that's going to require federal changes in tax law.
Yeah.
And things like that. So there's a lot of different things that have to go. There are laws that have to be passed that are changed by the federal government, by the state government. You know, I have whole chapters about what laws I think need to be changed. And so that's
very good. How do people get your book? It sounds like an important read.
Well, this book is on Amazon.
Okay.
So that's where I published it on Amazon. And there's Ingram Spark also has publishing of it, and that's more of an international type of thing. But they can get it. There's a Kindle version. There's a paperback version of it. They can get it on Amazon. So that's for the American audience.
Well, very good. Well, I think it's an important effort, and I'm glad that you're focusing in on it. It's a long haul to get that message out there and to get it to the place where our legislators see where we're at compared to where we need to be. But I appreciate you taking it head on. We need your perspective specifically out there. So that's important.
Well, thank you.
Yeah. Well, Dr. Hamner, it's been a real pleasure getting to know you and your story. Congratulations on retirement. I hope you're enjoying that. And I hope lots of people check out your book and they realize we need fundamental changes in our healthcare system.
Well, thank you.
Absolutely. Have a wonderful day.
You too. Bye-bye.
Well, once again, I want to thank Dr. Hamner for joining us today. I know you could sense it, his love and his care for his patients and how much he misses that aspect, and also his knowledge and his research that he has put in his book, Rescuing the Doctor-Patient Relationship. I hope you check it out. I know that I'm going to because I have felt, as he has for a long time, that we need some real change in the doctor-patient relationship. Not so much between the doctor and the patient, but all of the other stuff going on around that. So please check that out. Thank you once again for joining us on this edition of Patient Preferred Presents.